Hello, everybody. Thank you for attending this Industry Insights talk at the Society of Critical Care Medicine. My name is Tafiq Assad. I am a pulmonary and critical care physician who practices in Williamson Medical Center in Franklin, Tennessee. I am our ICU director and the director of our lung nodule program. And today I'm going to be speaking to you guys today about molecular diagnostics as well as procalcitonin and the diagnosis of pneumonia and antimicrobial stewardship in the intensive care unit. This is a very broad talk, and so hopefully I'll cover a lot and have some time at the end for questions. So here is my disclosure slide. So here's a broad overview of what I'm going to cover today. I'm going to spend some time talking about respiratory tract infections, both upper and lower respiratory tract infections broadly. But in my overview, I'm going to strategically leave out some of the diagnostic challenges that we have because I'm going to cover that separately at the end after that. I'm going to go over why it's challenging for us to diagnose upper and lower respiratory tract infections with conventional microbiologic techniques. I'm then going to spend some time talking about the BioFire, FilmArray, respiratory, and pneumonia panels as modalities that greatly improve our ability to diagnose upper and lower respiratory tract infections. And then I'm going to go over a few cases of patients that I took care of in my clinical practice, where I used procalcitonin as well as the BioFire FilmArray panels to aid in the diagnosis of upper and lower respiratory tract infections. So starting from the top. So upper respiratory tract infections are an extraordinarily common and expensive healthcare expense in the United States and world. So here's some data from 1 or 2 decades ago. In 2003, influenza led to about 30 million annual visits and a total cost of about $80 billion a year. Around the same time, non-influenza upper respiratory tract infections being 10 times more common than influenza, about 500 million cases annually, but about half as costly. And this is largely due to the fact that although other respiratory viruses are more common, they're not nearly as virulent as influenza. Now, I made some of these slides a little while ago, and then there was COVID-19. And so I don't even want to begin to estimate the total expense and burden on the United States and global economy secondary to COVID-19, but I think it's measured in trillions. Obviously, another talk for another time. Now, in terms of lower respiratory tract infections, community-acquired pneumonia accounts for about 5 million visits annually to outpatient clinics and emergency rooms in the United States every year. So quite a bit less common than upper respiratory tract infections, but the second most common cause of all hospitalizations in the United States. Now, this is actually a bit of a misleading statistic because the #1 cause of hospitalizations in the United States is childbirth. So it is the #1 cause of hospitalization from an illness. The costs are somewhere on the order of tens of billions of dollars. And again, this is somewhat old data. We don't have very recent data on the expense of pneumonia, with a high risk for recurrence and complications, and that many patients who are diagnosed with pneumonia will be rehospitalized for either a pneumonia-related complication or another within the same year. Now, hospital-associated pneumonia, ventilator-associated pneumonia, these are problems that are not nearly as common as community-acquired pneumonia, but carry an enormous burden on the healthcare system. They are thought to be more of a dose-response relationship, in that the longer that you were hospitalized, the longer that you were on a ventilator, the more likely you are to develop a hospital-associated pneumonia or a ventilator-associated pneumonia. And again, and then there was COVID-19. And so I don't know about you guys and your personal experience, but at my facility, I can tell you we have seen a sharp increase in the number of ventilator-associated pneumonias in our patients who are on mechanical ventilation related to COVID-19. Again, it's a really interesting talk, but really another talk for another time. And so how do we transmit upper and lower respiratory tract infections? Well, we know that fomite transmission, the transmission of droplets by touch, is a common cause in some forms, but not the most common. Inhalation of respiratory droplets is also probably one of the most common. And in the setting of lower respiratory tract infections, it's the microaspiration of pathogenic microorganisms from our upper airways down into our lower respiratory tract that is thought to be the most common. And so what organisms can lead to upper and lower respiratory tract infection? Well, we know viruses are extraordinarily common. Influenza, coronavirus, just about any virus can lead to an upper respiratory tract infection, and in the right circumstance, also a lower respiratory tract infection. Again, I don't have to remind you of this in the midst of a coronavirus pandemic. In terms of bacterial infections, we tend to think about lower respiratory tract infections as both either community-acquired pneumonia, in other words, organisms that you tend to get when you were living out in the community. That's your strep species, Haemophilus, Moraxella, and a number of the atypical bacterial pathogens. And then you're at increased risk if you were hospitalized or on a ventilator for developing resistant organisms as the cause of your infection, such as Staph aureus or one of a number of gram-negative rods that tends to be very resistant. Now, any infection, fungal, mycobacterial, parasitic, what have you, can cause an upper or a lower respiratory tract infection. But for the purposes of this talk, I'm not going to be considering those, and they do tend to have a different clinical presentation. So again, skipping how we diagnose for a moment, how do we tend to approach treatment in upper respiratory tract infections? Well, it tends to depend. There are a number of pathogens, specifically influenza, RSV, SARS-CoV-2, occasionally adenovirus, in which antiviral agents are available and sometimes used. But for the vast majority of viruses, supportive care alone is the recommended treatment. But I think the most important thing is that almost never should we use antibiotics in the setting of an upper respiratory tract infection. There are a handful of situations where bacteria can be the cause, but those are by far the minority, not the majority of cases. Other factors that we consider in our decision to treat patients with an upper respiratory tract infection is their overall immune status. And so patients who are immunocompromised are obviously more likely to develop serious illness, and we are more likely to treat. And just with any infection, timing really matters. And so the sooner that you diagnose and treat a patient with a viral illness or really any infection, the better they tend to do. Now, how about lower respiratory tract infection? Again, skipping the diagnosis for a moment, what are the recommended empiric treatment guidelines for lower respiratory tract infection? And so the American Thoracic Society and the Infectious Disease Society in America, in their most recent 2019 guidelines, have given some insight as to how we should approach the empiric lower respiratory tract treatment. And first, you need to assess whether your patient has MRSA or Pseudomonal risk factors. And then you need to assess how severe their illness is. And if they don't have MRSA or Pseudomonal risk factors, and it is a non-severe case of pneumonia, then you have a choice between a monotherapy with a respiratory fluoroquinolone or a combination therapy with a macrolide or less commonly doxycycline with an IV beta-lactam. In patients without risk factors for resistant pathogens who have severe pneumonia, then combination therapy is recommended over monotherapy with a macrolide or a fluoroquinolone plus an IV beta-lactam. Now, in patients who have risk factors for MRSA or Pseudomonas, then one of these broader coverage agents or a combination of them is recommended. Now, the whole point is the American Thoracic Society and the Infectious Disease Society of America give guidelines on empiric treatment. Well, the reason is that our ability to diagnose upper and lower respiratory tract infections is quite limited. So let's go into this. What is the diagnostic paradigm for upper respiratory tract infections? Well, we tend to rely on a lot of antigen tests in these situations, and you can see some of the data about the sensitivity of influenza or RSV or SARS-CoV-2 antigen tests. And some of them are fairly decent, some of them as low as 30% if you look at the sensitivity of RSV testing in adults. You could order individual monoplex PCR tests looking for one individual virus at a time, but that tends to be expensive and time consuming. And we know that the clinical presentation of a variety of different viral illnesses is identical. So whether you choose influenza or RSV or SARS-CoV-2 or some multiplex panel, it's really challenging because they all present similarly. There are a number of other less common testing techniques like immunofluorescence or viral culture, which really are not terribly practical or used much in clinical practice. Now, what's the diagnostic paradigm for lower respiratory tract infection? Well, it's really kind of a compilation of a variety of things. We look for characteristic symptoms, so infectious symptoms, fevers or chills, pneumonic symptoms, cough or shortness of breath, characteristic imaging findings on chest X-ray or CT scan looking for infiltrates suggestive of pneumonia, and then a laboratory evaluation, both routine lab testing, things like white blood cell counts, to some extent procalcitonin, and dedicated microbiologic testing. And the real problem is that when you look at symptoms and imaging and routine lab testing, we know that all of these findings are relatively insensitive. And it is impossible to distinguish which type of lower respiratory tract infection a patient has based on these things alone. And even non-infectious entities can present very similarly. So for that reason, if we want to isolate and diagnose the exact cause of a lower respiratory tract infection, we have to rely on dedicated microbiologic testing. And what do I mean by that? Well, the gold standard of diagnosing a lower respiratory tract infection in patients is the sputum, gram stain, and culture. Less so the blood culture, assuming a patient is not critically ill from their lower respiratory tract infection. I'm going to go into some of the limitations of sputum, gram stain, and culture in a moment. There are a number of antigen tests, both on urine and blood, looking at specific pathogens like strep pneumo and Legionella. Less commonly, there is serology for mycoplasma that we can use. And then there are nasal antigen or nasal PCR testing for a single virus, like I said before, like influenza or SARS-CoV-2 or RSV. Single bacteria, there's an MRSA nasal swab, or nasal panels, nasopharyngeal panels for multiple viruses and bacteria. And so in clinical practice, how do we do as clinicians when we try to diagnose lower respiratory tract infection using this compilation of diagnostic techniques? And I think the study that best highlights how bad we are at this is the 2015 study, sometimes referred to as the EPIC study, published in the New England Journal of Medicine. In this clinical trial from 2010 to 2012, 6 hospitals in the Chicago and Nashville area looked at patients in a highly cultivated clinical trial with suspected lower respiratory tract infection in the community. Strict eligibility criteria included signs of an acute infection, acute respiratory illness and symptoms, and radiographic findings consistent with pneumonia. And what they did was they tried to see how often they could diagnose the exact pathogen leading to the lower respiratory tract infection. And what did they find? In this highly cultivated clinical trial, in almost 2/3 of cases, no pathogen whatsoever was ever able to be identified. That was one really impressive and key finding. But another impressive finding was that in almost a quarter of cases, a virus was caused to be the only pathogen or co-detection as the cause of the lower respiratory tract infection. And in only 14% of cases was a bacteria found. So typically we thought lower respiratory tract infections most commonly caused by bacteria, and maybe that is true, but we are unable through conventional diagnostic techniques to isolate the bacteria. We also found that viruses are extremely common. And so what is the reasoning behind this limited diagnostic technique and diagnostic yield? Well, it has to do with the terrible yield of sputum culture in most patients. It's anywhere around 10% if you look at a number of different studies that analyze the true yield of sputum culture. Now, there are some circumstances, obviously, where yield might be better. Very ill patients, immunocompromised patients, bacteremic patients. Obviously, your ability to isolate the pathogen in those situations is improved. And obviously, adjunctive testing like procalcitonin, multiple antigen tests, or PCR can improve the yield. But when you have to order multiple tests to isolate the right pathogen, you incur cost and you take a lot of time. Now, why is sputum culture yield so poor? Well, it likely has to do with the fact that empiric antibiotics are so pervasive. How often do you take care of a patient who has been in the outpatient setting at a walk-in clinic, their primary care provider, other providers who've given them 1 or 2 rounds of antibiotics before they eventually come into the hospital? And how often is a patient given empiric antibiotics in the emergency department, and then you attempt to obtain a sputum culture 2 or 3 days later? In addition, a number of bacteria are fastidious, like Haemophilus influenza, and so our ability to culture them are just inherently limited by technique. And maybe most challengingly, there's a number of patients, for whatever reason, that can't provide a sputum specimen whatsoever. So even despite our interest and best attempts to obtain one, they can't give us one. And so it is for this reason that the American Thoracic Society and the Infectious Disease Society of America, in their most recent pneumonia guidelines, are actually discouraging the routine use of sputum culture, other than in cases of severe pneumonia or when a resistant pathogen is suspected. But they do suggest the use of rapid, cost-effective, sensitive, and specific diagnostic tests when available in order to target therapy. So I'm going to be talking about the BioFire panels momentarily, but before then, I just want to briefly mention procalcitonin, a biomarker that I'm sure many of you guys are intimately familiar with. As you know, procalcitonin is a peptide precursor to calcitonin, which normally in steady state is released predictably only in the thyroid gland. But in inflammatory conditions, particularly bacterial infections, triggered by a number of toxins that are very uniquely secreted in the setting of bacterial infections, we know that procalcitonin is synthesized in all tissues with detectable serum levels. And so it can be a useful adjunctive test to distinguish viral from bacterial infections. There are a number of different algorithms out there, and this is just one of many. But I like the look of this, and this sort of just gives you a reflection of how many places approach the use of procalcitonin, both as a way of deciding when to start antibiotics and when to discontinue them and stop them altogether. And there's no one absolute threshold, but there's some sort of tiered thresholds where in some circumstances, if you have a concentration greater than 0.5 or greater than 1 microgram per liter, antibiotics are encouraged or strongly encouraged, and less than that, discouraged or strongly discouraged. Furthermore, if you look at times when you want to consider stopping antibiotics, both a reduction to an absolute level less than 0.25, let's say, or a relative reduction by 80% or more, oftentimes suggestive of an adequately treated bacterial infection, and you can consider stopping antibiotics at that time. Now, procalcitonin has been studied numerous times over. There have been several systematic reviews looking at 26 trials from numerous countries, over 6,000 patients. And they found that when procalcitonin guided algorithms were used, antibiotic exposure can be reduced by upwards of 2 days per patient, with a reduction in antibiotic side effects, but most importantly, no difference in treatment failure or hospital or ICU length of stay. So you can get around, you can give patients less antibiotics with less side effects, but no reduced efficacy of their treatment. And maybe most shockingly from some of these studies, and we're still trying to wrap our heads around this, is that there's actually a reduction in 30-day mortality for places in which a procalcitonin use algorithm was used. Okay, now I would like to talk to you guys, if you're not already, about the BioFire respiratory and film array pneumonia panels. So the BioFire system is an automated one that extracts and purifies nucleic acids from a sample. Multiplex PCR is performed, and viral and bacterial DNA targets are identified. It is really quick, 2 minutes of sample handling time, minimal pipetting required, not one that requires much technical skill whatsoever, and results are generated anywhere from 45 minutes to 1 hour. Now, there are a number of different body fluids in which the BioFire film array panel can be run. There is a blood culture panel, which can be run on blood specimens from bacteremic patients. There's a meningitis and encephalitis panel that can be run on cerebral spinal fluid, a gastrointestinal panel that can be run on stool specimens. And what I'm going to talk to you guys today about is the upper respiratory panel, which can be run on a nasopharyngeal swab, and the pneumonia panel, which is their newest offering, which can be run on either an endotracheal aspirate, a bronchial alveolar lavage, or an expectorated sputum specimen. As you'll see, there are a number of different pathogens available on all of these panels, and the sensitivity and specificity approaches 100% for almost all pathogens. Here are a couple infographics just to kind of give you a visual about how this whole process works. And so you insert the pouch being the laboratory workhorse of the BioFire film array system, into the loading station. A hydration solution is injected, a specimen is injected from the sample that you want to test. No precise pipetting is required, and then that pouch is loaded into the film array system, and you press a button and you get results in an hour. If you blow up the BioFire film array pouch, and this is really, like I said, the workhorse of their system, it is a miniature laboratory all-in-one. Starting from the left, you inject a specimen, a sample, cell lysis occurs, DNA and RNA purification occurs, and multiple PCRs are run, ultimately resulting in a detection of viral and bacterial DNA. I'm going to start with the BioFire Respiratory 2.1 panel. This is the one that's run on the nasopharyngeal swab. And with this, you receive a ton of information on a variety of respiratory viruses, 18 in total, and 4 bacteria. Going through the viruses, you'll see that there is a lot of detailed speciation on specific subtypes of coronavirus, influenza, parainfluenza, and as I have highlighted, SARS-CoV-2 is available on this panel as of now. There are 4 qualitative bacteria. These are some of the bacteria that are more commonly known to cause upper respiratory tract infections. And when I say qualitative, what I mean is for all of these, the viruses in the bacteria, it is reported as detected or not detected, yes or no. Now, when you look at the film array pneumonia panel, which I'm going to shorten to PN for future slides occasionally, you'll see there is a lot more information on this panel. You get 33 total targets. So let's start on the left first. There are 8 viruses. So as compared to the respiratory panel, not nearly the degree of speciation for the different subtypes, but you get the seasonal coronavirus, influenza A and B, parainfluenza, and the other ones that you see. For right now, SARS-CoV-2 is not available on this panel. but it is my understanding that that is something they are working on and hoping to release in the near future. There are 3 qualitative bacteria, the ones that are known to most commonly cause atypical bacterial pneumonia, Legionella, Chlamydia, Mycoplasma, reported as detected or not detected. There are 15 semi-quantitative bacteria listed in alphabetical order, and you'll see this is a nice compilation of common causes of community-acquired pneumonia and hospital-associated pneumonia, both gram-positive species and gram-negative species. And when I say semi-quantitative bacteria, what I mean by that, instead of just reporting them as positive or negative, if they are detected, they are reported as what they call their bin value, which is a relative reflection of bacterial burden. And so they report it as 10 to the 4th, 10 to the 5th, 10 to the 6th, or greater than or equal to 10 to the 7th copies per ml. Not the same as a colony forming unit, but a sort of correlate as to, that sort of idea. And then finally on the right, you get information on 7 antimicrobial resistance genes. Starting at the top, the MEK-A/C and MREJ genes, when positive in the setting of a staph infection, are known to confer Staph aureus resistance to methicillin. There are 5 carbapenemase resistance genes, and then there's the most common cause of VSBL and gram-negative rods, the CTXM gene. And so it is important to know that these antimicrobial resistance genes are only reported as positive or negative in the setting of a corresponding bacterial detection that makes sense. So MEK-A/C and MREJ only if there's a staph species, and the carbapenemase ESBL only in the setting of a corresponding gram-negative rod. So now going through some of this, the BioFire respiratory panel has been around for a while, and a number of studies have shown that it decreases lab turnaround time significantly. It can decrease hospital and ICU length of stay, antibiotic duration, inappropriate time in isolation, healthcare costs, and unnecessary medical procedures. Now, the BioFire pneumonia panel is a little bit newer, and I'm going to go through some of the data about it right now. One of the best clinical trials that I think that really summed up the power of the FilmArray pneumonia panel compared to culture was published in 2020. In this study, they looked at almost 850 patients with BAL and sputum specimens at 6 different academic medical centers and pediatric hospitals from 2016 to 2017. At any of these institutions, if somebody ordered a BAL culture or a sputum culture and there was some residual specimen and it was never frozen, it was sent to a reference laboratory. And what they did is compared the FilmArray pneumonia panel to what this reference laboratory did, which was called comprehensive culture. So what that means is that for every specimen that they obtained, they attempted to plate it on 4 different media types at 4 different concentrations. So for every culture, you had 16 different plates attempting to culture the specimen. And I think we can all agree that that is a bit more comprehensive than even the best microbiologists at our relative institutions. And what did they find when they compared the FilmArray panel to this comprehensive culture? Well, starting on the left, if you look at sputum specimens, in 39% of cases, they found that both modalities were unable to detect bacterial pathogen. In 34% of cases, both were able to detect the same pathogen. Those were the concordant specimens. But in 27% of cases, over a quarter of the time, the BioFire FilmArray panel was able to identify a bacterial target, whereas comprehensive culture could not. And the opposite was true in less than 1% of cases. When you look at BAL specimens, you see something sort of similar. In about 2/3 of cases, neither modality was able to identify a bacterial target. In 16% of cases, both were able to identify the same one. But in almost a quarter of cases, again, the BioFire FilmArray panel was able to identify a bacterial target, whereas comprehensive culture could not. And this is actually not the truest and fairest of comparisons because comprehensive culture is only looking at bacteria, whereas the BioFire FilmArray panel can give you some information on respiratory viruses. And when you factor that in, you can see that in about 1/3 of cases in the sputum specimens and 16% of cases in the BAL specimens, a respiratory virus was detected either independently or as a co-infection. And so really, when you compare the yield in the study of comprehensive culture, which takes several days to return, to the BioFire FilmArray panel to identify a viral or bacterial target, you double the yield in sputum specimens and triple the yield in BAL specimens. Now let's look at some other data about the FilmArray system when compared to culture. In a number of studies, almost all published within the past couple or few years, have demonstrated the comparativeness in terms of positive % agreement, negative % agreement between the FilmArray panel and culture. And a number of studies have found that the yield of the BioFire FilmArray panel to detect any pathogen is upwards of 90%. And when compared to culture, can be increased by upwards of almost 40%. Now, one important thing to remember and to keep in mind is that this is a limited panel of viruses and bacteria. So there are a number of bacteria and viruses, for that matter, that are not available on this panel, and something that you have to keep in the back of your mind and use your best clinical judgment. Here are some of the common ones like Citrobacter, Enterococcus, or Haemophilus parainfluenza, Morganella, Stenotrophomonas. If you have clinical information that suggests bacterial infection and a high clinical suspicion for any of these bacteria, then obviously you're not going to just act on the BioFire FilmArray panel alone. You're going to use your best clinical judgment. Now, studies have shown that antibiotic or isolation changes can be made in upwards of 70% of cases. So these are not just academic, interesting, oh, okay, we know exactly what they have. People were able to de-escalate antibiotics or discontinue antibiotics or escalate antibiotics and make a real change or place a patient on an appropriate level of isolation based on this information. You could give patients, based on one study, 6 less antibiotic days on average based on this information. And another study even found that it was cheaper to use the BioFire FilmArray panel as compared to performing a number of unnecessary ancillary tests. And although not every study looked at this, invariably every study would have shown that the turnaround time, when you compare normal culture, which takes 2 days or so, and then sensitivity testing, which takes another day or so, compared to the turnaround time of 1 hour, could increase your turnaround time by 2 to 3 days. And so one general approach, a way to sort of put this all together, is that if you have a patient who is exhibiting symptoms of acute respiratory infection, you have to decide whether you think that lower respiratory tract infection is likely based on chest imaging. And if they do have symptoms of infection and they do have infiltrates on chest x-ray, ask the question, can the patient produce a sputum specimen? And if the answer to that is yes, and then you can run the BioFire FilmArray pneumonia panel on their sputum specimen to identify the pathogen if it is available, either viral or bacterial. Now, if the patient either does not have a cough or is unable to produce a cough that is adequate based on your best attempts, then that would be an opportunity to run the nasopharyngeal swab and to see if the patient has any of the corresponding respiratory viruses on the nasal swab or some of the atypical bacteria that can cause lower respiratory and upper respiratory tract infections. Now, if the patient improves, great. But if your patient declines at any point and ends up either a candidate for bronchoscopy or intubated on mechanical ventilation, then you can always consider at that point running the BioFire FilmArray pneumonia panel on the patient's lower respiratory tract specimen, either an endotracheal aspirate or a bronchial alveolar lavage. So now, just to wrap up the last part of this talk, go through some specific cases in which procalcitonin and the BioFire FilmArray respiratory and pneumonia panels intersect and how it sort of factors into clinical management in my ICU. So this first case, and you will see that my cases are pretty declaratively titled and kind of give away the ending, but that's okay. The first case I call discontinue, exclamation point. 66-year-old male with a history of asthma, admitted with fevers, chills, cough reportedly productive of green sputum at home. Came to our ER, he was febrile, he was hypoxic, needed some supplemental oxygen, and his chest x-ray showed a fairly non-specific pattern of bibasilar infiltrates greater on one side than the other. He had an elevated white blood cell count. His procalcitonin was in that sort of middle zone. Depending on what cutoffs you're using, this would have been sort of in the unlikely to be a bacterial infection, but not exactly like a slam dunk one way or the other. We attempted to get a sputum culture. We attempted to actually get a pneumonia PCR panel, but the patient really was just unable to expectorate once he came to the hospital. So one of those situations where I had a history of coughing up phlegm, but when push came to shove in the hospital, we were really unable to attain another specimen. And so the patient was presumed to possibly have a lower respiratory tract infection, was started on antibiotics. In this case, he was started on levofloxacin and treated for a community-acquired pneumonia. Unfortunately, the patient really didn't get better pretty quickly. He developed worsening bronchospasm and wheezing and chest tightness, and he started to complain of diarrhea, which we were assuming and it was attributed to the antibiotics that he received. So at that point, we thought, okay, well, if he can't produce a sputum specimen, let's just see, and let's run a BioFire RP2 panel on a nasopharyngeal swab. And we found that he had human metapneumovirus. I don't know about you guys, but we saw a number of cases last year in particular where patients were critically ill, extremely bronchospastic, a lot of coughing, just really sick from human metapneumovirus. And so what we did is we discontinued antibiotics. we focus more on, bronchospasm and airway clearance, and we put him on steroids and nebulized bronchodilators, and gradually he improved over the subsequent few days. And so I think this case highlights a number of points. First, a relatively low procalcitonin in here was a clue. Although it's not an absolute test, it was a clue that maybe this was a viral pathogen. But I think we were all clouded in this case by his fevers, his white blood cell counts, his infiltrates, and his history of green sputum. This case also shows that the BioFire respiratory panel can allow for rapid detection of a specific pathogen, and in this case, a viral pathogen, in a patient who was unable to expectorate a sputum specimen. And in doing so, it allowed us to immediately discontinue antibiotics in a patient who would not clinically benefit from them and was already experiencing some side effects from them. I think this case, as many of the cases with the BioFire FilmArray panel demonstrate, antibiotic stewardship is extraordinarily important in our patients that are hospitalized and in the intensive care unit. We give a lot of antibiotics in the hospital setting, and we know that even in situations where they are appropriately given, 1 out of 5 patients has a significant adverse effect from the antibiotics that we give them. And that can range from a C. diff infection to an increased prevalence on a patient level, on a hospital level of multi-drug resistant isolates, or toxicities and side effects of a variety of different kinds. Now, we know this is better for the patients to only get antibiotics when appropriate and to avoid side effects when possible, but we know it's also better for the healthcare system as we are developing increased antibiotic resistance in our entire hospital systems. It can reduce hospital length of stay and minimize IV antibiotics and get patients to rehab or discharge home sooner. It's really better all around the board for all of our patients to only get antibiotics when absolutely indicated. So my second case, I'm going to call the de-escalate story. This is probably the most common type of story, type of case in which the BioFire FilmArray panel comes into play in my hospital and my clinical practice. So this was in the end of 2020, December or so. 73-year-old female, was otherwise fairly healthy, other than obesity, came to the hospital with a number of systemic symptoms: fevers, cough, anorexia. They'd really been going on for at least a week prior to her coming to the hospital. She reached out to her PCP, who arranged for a nasopharyngeal PCR for COVID-19, which was positive. And so she came to the hospital with a known diagnosis of COVID-19, but was failing to thrive at home. She was found to be hypoxic on arrival to the emergency department, placed on supplemental oxygen. At this time in history, dexamethasone and remdesivir were just starting to be used, and so we placed her on dexamethasone and remdesivir and admitted her to the hospital. All of her labs and imaging and testing, everything was really consistent with COVID-19. I think we've all seen versions of this chest X-ray numerous times over the course of the pandemic: bilateral, alveolar, and interstitial infiltrates suggestive of a viral pneumonia. This was the day she came to the hospital. Unfortunately, as we've all seen before, over the next 2 days or so, her oxygen requirements gradually increased. She was placed on high-flow nasal cannula. At this case and time and point, we were using high-flow nasal cannula more liberally. Earlier in the pandemic, we were a little bit more reluctant to do so. But unfortunately, despite high-flow nasal cannula, the patient became tachypnic, increasingly hypoxic, encephalopathic. She did have a worsening cough, but unfortunately, largely because of her encephalopathy, was really unable to produce much sputum, or at least allow us to collect a sputum specimen. She had low-grade fevers, ranging to the 99.5, 100-degree range. Her white blood cell count was initially fairly low, but has kind of gradually, incrementally increased over the few days that she was in the hospital. And her procalcitonin, on about 4 days into her hospital stay, was gradually increasing. When she came into the hospital, it was in the 0.3 range, and then the day that I'm describing now, it increased to 0.83. And ultimately, because of her worsening respiratory status and hypoxia, we elected to intubate her. And this is her chest X-ray only 4 days after her admission. Again, something that I'm sure all of us have seen far too commonly, which is that she's developing progressive, bilateral, dense infiltrates and consolidations, and ultimately ARDS secondary to COVID-19 pneumonia. So what I'm going to do now is I'm going to run through a sort of what-if scenario, and that what if we didn't have the BioFire FilmArray pneumonia panel, and what would the normal timeline have been had we relied on sputum culture, endotracheal aspirate culture alone, and what decisions we would have made compared to what happened when we did have the panel. And so, as a sort of common practice for us, once a patient gets intubated, particularly if it's for a respiratory illness and if we don't have an existing sputum culture, we performed an endotracheal aspirate to see if she had any lower respiratory tract secretions. And in this case, she did. And we ran a gram stain, and it was a fairly inflammatory specimen with significant white blood cells and gram-positive cocci and gram-negative rod. In my experience, we almost always get polymicrobial detection on the gram stain. So we would have been given a choice at this point. You could have made the case to maybe hold off on any antibiotics and just wait and see what the culture shows. But as was commonly our practice at that time, if we were worried about a lower respiratory tract infection and with that borderline procalcitonin, we probably would have started her on broad spectrum antimicrobials, which in hindsight we would have known would have been way too broad. Day one, we would have found that a culture was in progress, but without information, without any specific speciation yet, we probably would not have been able to de-escalate antibiotics yet. But if we hadn't started antibiotics at this point, this would have been an opportunity to start the broad spectrum antimicrobials as we're awaiting further speciation. One day later, we would have found that she was positive for Staph aureus on her culture, and we could have confidently dropped whatever gram-negative rod coverage. Maybe she was on vancomycin and cefepime or Zosyn or what have you. And so we would have dropped that and just placed her on vancomycin, which again, in hindsight, we would have known would have been way too broad because her sensitivity testing demonstrated that she had an MSSA isolate. And so at that point, 3 days into her becoming intubated for worsening respiratory failure from both COVID-19 and a bacterial pneumonia, we would have started her on the appropriate antibiotic cefazolin. But ultimately, because we had the BioFire film array panel that we ran immediately after she was intubated on her endotracheal aspirate, we would have found that she had Staph aureus, a greater than or equal to 10 to the 7th bin copies per ml. And we would have found that the MEK-A/C and MREJ genes were not detected. So instead of waiting for 3 days, either with inappropriately broad or inappropriately inadequate antibiotics, we started her on cefazolin immediately after she was intubated within 1 hour. And what we did is we trended her procalcitonin over the next week, and we noted that it appropriately dropped to a value of 0.13 after 5 days, and she completed 7 days of cefazolin for a standard treatment course for staph pneumonia from a ventilator, or this actually was a hospital-associated pneumonia. Unfortunately, though, as was too often the case, despite appropriate antibiotic use and despite full supportive measures, the patient expired about 2 weeks after her admission. And so this case highlights a number of different points. First, serum procalcitonin was again a pretty useful detection of an early sign of bacterial infection. It's not always perfect. We know that sometimes serum procalcitonin can be elevated in viral illnesses and low in bacterial illnesses, but it was a clue in this case that maybe this was more than just COVID-19, but maybe she was developing a secondary bacterial infection. It also shows that the BioFire film array system is rapid. So we can change our management within an hour as compared to waiting several days. And if you had waited for conventional culture and sensitivity testing, which in this case ended up getting us the right answer, we'd have had her on inadequate or inappropriately broad antibiotics for 3 days. So one thing that I love about this case and what I've just relied on time and time again is in the setting of Staph aureus infections. And I can tell you in our COVID-19 pandemic, we saw a number of cases of Staph aureus infections, both MSSA and MRSA. It's the ability to use this MEK-A/C and MREJ genes immediately to identify cases of MRSA and MSSA. And we've found 0 cases of discordance between the MEK-A/C and MREJ genes from the ultimate sensitivity testing that came out of patients with Staph aureus infections. And so it was 100% reliable in our clinical practice. And it allows us to reduce the use of unnecessary use of vancomycin and linezolid in these patients. Okay, the third and final case that I'm going to go over, I call this the Escalate case. So this was a 45-year-old male several years ago prior to the COVID-19 pandemic, admitted to the hospital from inpatient rehab. He was recovering from a left above the knee amputation and a hemicolectomy. Despite a fairly young age, this patient was very frail and chronically ill. In his rehab facility, he was found to be poorly responsive. He had unstable vital signs, he was hypotensive, tachycardic, hypoxic. Everything pointed to severe pneumonia. He had a markedly elevated white blood cell count. His lactic acid was elevated. His procalcitonin was not subtly increased. And he had chest x-ray findings, which I'll show you momentarily, which were suggestive of pneumonia. And so he was diagnosed with septic shock secondary to it. Central line was placed. He was immediately intubated in the emergency department. We started on broad spectrum antimicrobials with vancomycin and cefepime. Here was his chest X-ray on the day of admission. You can see intubation, central line in place, and bilateral, mostly basilar, somewhat nodular infiltrates, particularly in his left lower lobe, suggestive of pneumonia, possibly aspiration. So again, I'm going to run you through sort of what if scenario if we didn't have the BioFire film array panel, and then what we were able to do right away because we did. So intubated immediately, we ended up sending an endotracheal aspirate, and he had 3+ white blood cells and a number of gram-positive cocci and gram-negative rods, and so a very polymicrobial specimen. So at this point, I think we all would have agreed with broad-spectrum antimicrobials to cover this patient for all potential infections. We got confirmation a day later. We're still going to wait and keep him on similar coverage. The next day, we found that those gram-positive cocci were probably oral diphtheroids and normal respiratory flora, but the true pathogenic infection was that of E. coli. And so at that point, we would have confidently stopped vancomycin or linazolid, kept him on cefepime alone, only to find out the following day that he ended up having an ESBL E. coli isolate. And only at this point, finally, 3 days later, will we have put him on meropenem or some comparable antibiotic to treat an ESBL infection. But again, this is the what if we didn't have it. And what we actually did find was that, again, immediately after he was intubated, he was detected to have E. coli at the greater than 10 to the 7th copies per ml bin, and the CTXM gene was detected. And so with this information, we started him immediately on meropenem. So again, without delay, without inappropriate antibiotic exposure, without putting him on anything he didn't need, we immediately put him on meropenem. And ultimately, he stabilized and was extubated 3 days later. We trended his procalcitonin. It dropped down to a nadir of 0.81, greater than 80% reduction from its peak. After 5 days, he completed a week of meropenem. And so this case highlights, once again, that procalcitonin in this setting, it wasn't terribly subtle, is often predictive of bacterial infections. And once again, the BioFire film array pneumonia panel can lead to rapid detection in immediately changing our clinical management. So this case highlights the opposite end of the antibiotic spectrum in our intensive care units, which is that of emerging antibiotic resistance. And so the CDC estimates that drug-resistant infections are on the rise, affecting millions of people a year, leading to tens of thousands of deaths annually in the United States and even more globally. And the problem is that the empiric broad-spectrum antimicrobial regimen that we have chosen commonly for some of our patients doesn't cover some of the resistant pathogens that we're seeing more commonly, such as VRE or ESBL infections or carbapenemase infections. Now, it is important to remember, and this is something that can't be stressed enough, this assay is not the same as sensitivity testing in the ICU. This is detecting the presence of resistance genes. This is not stating whether or not a particular isolate is going to be sensitive to a particular antibiotic. But I think we all agree that in a situation like this, where somebody has a high risk for a resistant pathogen based on chronic illness and recent hospitalization, when you find the presence of this gene, I think most of us would treat empirically, at least as we wait for sensitivity testing to return, which ultimately agreed with the presence of a CTXM gene and an ASBL isolate. So I quickly want to go over a few false positives, false negatives in the procalcitonin and BioFire panels, starting with procalcitonin. There are some situations, as I've described, SIRS, trauma, shock of any kind, certain medicines, cancer, autoimmune illnesses, or other infections that can lead to a false positive procalcitonin. And we've seen in cases of severe COVID-19 pneumonia that patients can have a mildly elevated procalcitonin. So it is absolutely not a true, there's not one cutoff which is perfectly accurate at distinguishing viral from bacterial infections. And likewise, there are some situations where you get a false negative. So if somebody has a very focal, localized infection, oftentimes you don't have a significant procalcitonin response. If you draw it way too early in patients, you sometimes get a low value, even though if you checked it several hours or days later, you would have detected it positive. And lastly, and some reason that we don't fully understand, in bacteremic patients, occasionally the procalcitonin is suppressed. Now, if you look at the BioFire panel, there are a number of situations where you get a false positive. And you have to be mindful of polymicrobial detection. I didn't spend much time talking about this in my cases, but think about it. If you have patients who have chronic lower respiratory tract infection, colonized with a number of different bacteria, people with bronchiectasis or COPD or what have you, you're going to get multiple positives, and not all of them may be pathogenic. And in these situations, you're going to have to use your clinical judgment. I can say that it is definitely the case in which if you rely on the bin counts, it is generally a pretty good clue as to whether or not patients have a true pathogenic infection. And so in cases where it's greater than or equal to 10 to the 7th copies per ml, I've never seen that be not confirmed on culture. But when you have the lower bin counts, the 10 to the 4th, the 10 to the 5th, sometimes you're going to have to use your clinical judgment and determine if patients have true infection or whether or not it is just a colonizer. Now, also, there are some false negatives, and I spent some time talking about off-panel pathogens. There are a number of different pathogens that aren't going to be available on this limited panel. And so you're going to have to use your judgment and be aware of some of the bacterial or viral pathogens that aren't on the panel. And also be aware that the quality of the specimen that you receive. How deep is the nasopharyngeal swab? Is this patient giving you a deep lower respiratory tract specimen, or is it more oropharyngeal contamination? All of that is going to affect the quality of the test. And lastly, just by the nature of our BAL specimens, they're more dilute. And so you're going to get a lot less bacteria or a less virus per volume. And in those situations, you're going to possibly get false negatives, even in the presence of infection. But overall, I think I've summarized that upper and lower respiratory tract infections are common. They're morbid illnesses. And at the moment, we don't have very good diagnostic testing available. And so all too often, we treat patients empirically, oftentimes with antibiotics that they don't need. So in conjunction with procalcitonin, the BioFire Respiratory Panel 2.1 and the pneumonia panel, I really think have the ability to rapidly diagnose or exclude very specific pathogens, leading to early de-escalation of antibiotics or discontinuation of antibiotics for viral etiologies and sensitive pathogens, and the early escalation of antibiotics for resistant pathogens. So in summary, I think it really improves the care that we provide of our patients and ultimately can lead to less money in the care of our patients. And so with that, I am going to stop my screen share and take any questions. 1 second. Okay, so I received a presentation or a question. It's difficult to lean on procalcitonin when reliance with algorithms in published studies is so poor. Hold on. Yes. Do you have any data that suggests de-escalation and antimicrobial stop altogether with the combination is actually practiced? Well, I do know that that's a good question. And I know that compliance with procalcitonin algorithms is quite poor, but I think that actually is actually good to answer your question. And so if you follow a procalcitonin algorithm to the T, I think everyone, most of the time, patients objectively get less antibiotics and get less side effects and do better. But many studies that looked at it in real world found that compliance can be as low as 40%. And even with low compliance like that, I think we find that overall patients get exposed to less antibiotics and less side effects. And so I don't know that's a bad thing. I think that in some ways, it proves that even in real world practice, patients do benefit from procalcitonin-based algorithms, even when compliance to the T is not pristine. Okay. Any other questions? So I'm being asked, can I describe how the pneumonia panel results are being reported at my facility? And so obviously this is all going to be dependent on your electronic medical records and sort of how your individual institution is going to choose to result it. But in my facility, what we do is it gets resulted in sort of a sort of PCR section. They call it the serology section, which is not the best name. And every sort of data point is its own row. And so for every pathogen that's available, it's going to get its own row, and it's going to be reported as detected or not detected. And we use a color for the detected. It's like red, so it stands out more, and not detected are going to be in black. And then if you want the bin count information, for every positive, we have a little bubble, and then you have to click on that. And it tells you whether it's the 10 to the 4th, 5th, 6th, or greater than or equal to 10 to the 7th copies per ml. And we found that that was the best way to display the information, but also not to overwhelm people, because you can get lost in some of the numbers and digits. And so ultimately, I found that that was sort of the way to sort of sum it all up in a sort of clean way, but also to display the data on the bin values, because I'm going to say in my personal experience, it's extremely useful. Again, I've never seen a case where the greater than or equal to 10 to the 7th copies per ml was not truly pathogenic. And so knowing that something is at that amount gives me even more confidence that the patient has a true lower respiratory tract infection. In situations where it's lower, like the 10 to the 4th, again, as I said, clinical judgment is extremely important, and you're just going to have to use all of the other pieces of information to put it together. Other questions? Well, I think we're going to wrap it up there. We finished a few minutes early. My information, my email should be available. Feel free to email any questions, and thank you guys for listening.